talked about bacteria as agents of infection. But of course there are others. But we'll see later on in the talk that many of these different agents of infection all share some similar patterns and characteristics. So the protozoal infections, just as a biology reminder, a protozoa is a much more complicated single-cell organism than you typically find. So all of these are single-celled organisms, but they have complex lifespans and complex different phases of their life. They're really quite amazing little things until they start causing disease. So one of them that you will see in gynecology is called Trichomonas vaginalis, and it causes an STD that affects both men and women in sort of easy to imagine symptoms. Basically GU effects: irritation, itching, pain, discharge. It is a mobile organism, so it has a flagella. So one of the ways to diagnose Trichomonas is to look at it, take a vaginal sample and look at the mucus under the microscope, and you'll actually see the little trick germs swimming around. So it's a very quick and easy determination to make. It's problematic because it can attach to mucous membranes, so it can be difficult to get rid of. And it does cause, like I say, inflammation. So itching, redness, discharge, all those things. Most antibiotics won't even touch Trichomonas because it's a completely different species of bug. So you have to use tailored treatment just for Trichomonas. Plasmodium is very common worldwide, even though we don't see it much here in America. It's the causative species for malaria. And here again, it may be a single-celled organism, but it has kind of a complicated life cycle. It's transmitted by mosquitoes, and part of its life cycle, it lives inside of mammalian red blood cells, so it's not just humans that are affected, but cows, sheep, livestock animals can also get malaria and be a reservoir for it. And the infection causes red blood cells to swell up and rupture. That releases new infectious organisms. You get bitten by a second mosquito. Now it carries the malaria to somebody else. So it's a classic transmission cycle there. The classic symptoms of malaria are a cyclic fever is the one that you find on board exams, where the fever gets very, very high and then it drops, and very, very high and then it drops. And that can go on for weeks and weeks. In certain parts of the world, people take anti-malarial medications all the time to prevent the spread and to prevent the disease. Amoebas are also a group of protozoas, or a group of protozoa. They are, again, single-celled organisms. They are also mobile, and I think they have one of the coolest forms of mobility that there is, and that is they use pseudopodia. So if you've ever seen like the movie The Blob, where you have this big massive thing and it kind of rolls towards stuff, that's how the amoeba gets around in the water. It sort of just rolls places. It can cause a bad diarrhea called Entamoeba histolytica, and it's problematic because it's transmitted in spores. Spores are something that some single-celled organisms can make. And basically, it's like they become very, very small, and they put up this very armored wall around themselves. So spores can last in the environment even for years. And because they're so small, they're very difficult for our drinking water treatment systems to get all of the spores. So every once in a while in America, you'll hear about an outbreak of this. This is typically called amoebic dysentery. And they'll ask people to boil their water because that's one of the few ways to actually destroy these spores. A number of the modern home water filtration systems actually filter down to this size just for that reason, because these amoebas, their spores do sometimes get through. So it's you get them from contaminated water sources. So not only an ingestion of water, but swimming in a contaminated waterway can also get you this amoebic dysentery, and it's no fun. All right. Other agents of disease, this one usually makes people cringe. The Helminths are worms. and these are macroscopic, oftentimes parasitic organisms. Usually the infection is by eggs, so eggs are ingested or eggs find their way into the body through a contaminated water source somehow. The eggs hatch, and then the worms live out at least part of their lifespan in the digestive tract. So the classic tapeworm, which we all heard about at some point in our lives, lives in the intestine, and it can get to be like 6 feet long and has a tendency to strip all your nutrients away. That's one. Pinworms are much, much more common. You'd think that you wouldn't see worm infections in this country with as clean as all of our stuff is, but pinworms you still see in pediatrics. Every month, there'll be at least 1 or 2 kids that has pinworms. The classic symptoms there are they have anal itching, because the pinworms, they live in the large intestine, and at night they come out to mate and lay eggs. So one of the classic tests for this is called the Scotch tape test, where you take a clear piece of tape and you kind of stick it on the skin near the anus, and you pull it off very gently, of course, and you find the little eggs that are stuck there. So pinworms really do happen even in America. It makes kids very miserable, yeah.
Is it true that burnt toast helps with pinworms?
I haven't heard that one.
Heard of that? And I don't know where it came from.
I always went with metronidazole instead.
We should try burnt toast. I mean, obviously all the...
What, do you eat the burnt toast? Do you put the burnt toast in the butt cheeks?
Instructor tell me that.
I have to ask.
She was a nurse practitioner, and she said that, I don't know.
Burnt toast, that's a new one on me.
Mm-hmm.
Tapeworms, and then Ascaris is a giant roundworm. It's much like a tapeworm, but pinworms are one you really do see. Another really weird agents of disease are called prions. Prions weren't even known about 100 years ago, but they're proteins that behave like pathogens. So instead of being a virus, that tricks the cell's machinery into making copies, these are self-replicating proteins that attack other proteins. And since proteins are so critical in how the cell functions, these prions can cause disastrous results in tissues. Probably the most famous of these is Creutzfeldt-Jakob disease, although not anymore. Now the most famous one is mad cow disease. Mad cow disease was a prion disease. So how do we avoid these? It's hard because they'll resist a lot of disinfecting practices. So basically, anybody who's handling nervous tissue from a human or an animal has to be particularly careful in their technique of universal precautions, because these prions are spread from neurologic tissue and usually into the oral route. There are a number of cultures of ancient people that actually used to eat brain from either animals or other people, and they also were a source of this disease for a long time. All right. So in addition to the pathologic microorganisms that invade us and give us trouble, we also are host to a lot of bacteria that just live with us our whole lives. So we call those the resident flora, and we talked a little bit about that in our immunology talk last time. But these are just resident populations in these areas are all collinated by bacteria. Typically, they don't do any harm, and they can actually help to prevent infection of pathogenic bacteria because they take up all the space. So like in the large intestine, for example, one of the reasons why it's hard to get one of these infectious bacterial diarrheas is because the bacteria that live in our large intestine take up all the space and all of the niches, so there's nowhere for anything to get going. Also, the bacteria in the large intestine make us vitamin K, which we need for blood clotting. But these flora come up in treating infections because the antibiotics that you take or give to a patient, they don't care what kind of bacteria they kill. They'll wipe out any bacteria that is sensitive to that antibiotic. So a very, very frequent side effect of antibiotic treatment is diarrhea, because the antibiotic wipes out your resident flora, and that causes imbalance, and then you have a diarrhea that follows the antibiotics. People used to think that the antibiotics themselves cause diarrhea. Now we know it's the effects on the bacterial population that do that. Another result you can get from antibacterial therapy is fungal infection, particularly vaginal yeast infections. And there again, if you knock out the bacteria, it opens up space for these other organisms to thrive, and it can kind of knock things out of balance. So for the diarrhea version, one of the common treatments is when people are on antibiotics, you also have them eat live culture yogurt every day. What do they call that? Probiotics. To try to keep those natural bacteria, flourishing. All right. So this is kind of a question from last time. Which of the following is a characteristic of rickettsia? In just a minute, I got to click 2 buttons here. There we go. Here today. Trisha. All right, that's everybody. So the answer here is the rickettsia are, in fact, very small gram-negative bacteria that live inside of cells. So they're intracellular microbes. Their biggest claim to fame is the disease Rocky Mountain spotted fever, which is a vasculitis. In other words, they preferentially attack the linings of blood vessels, so it can cause major problems with clotting and blood flow. All right, I think we got another one. Which of the following is not classified as a protozoan agent of disease?
It's a fungus protozoal.
That is part of what the question is asked, Carolyn.
Sorry. Okay, thank you.
All right, jump in there, last 4 people. You got just a few seconds left. All right, good. So the answer there is tinea pedis. Tinea pedis, this is athlete's foot, commonly known as, and it's actually caused by a fungus. And I know we didn't talk about fungi, but Candida is a fungus. Tinea pedis, tinea curris are also fungal infections that affect the skin. We'll talk more about those when we get to the skin. But these 3, Plasmodium is the malaria bug, Trichomonas is an STD, and then the Entamoeba histolytica causes that amoebic dysentery that we talked about. All right, so which of the following is a characteristic of resident or normal flora? All right, so we know that resident flora is the microbes that live with us all the time. And it is incorrect to think that they exist in all areas of the body. The fact of the matter is the body, for the most part, is sterile on the inside. Otherwise, we would just provide an excellent environment for bacteria to grow. In reality, that's an infection. Is anytime there's bacteria growing in a place that doesn't normally have bacteria growing, that's a bacterial infection. So the only places that we find resident flora are in areas that communicate with the outside world. So like the upper respiratory tract, resident flora. The lower GI tract, resident flora again. But most of the body is sterile. And it is true that because the different areas where we have resident flora are profoundly different, the mouth and respiratory tract and nose are very different than the large intestine, the species that inhabit those things are very, very different. So the answer there is B. And usually they are of some benefit, and no, it's not just bacteria, it's also yeast as well. All right, so those are the agents of infection. Bacteria, the protozoa, a little bit about yeast, the prions. But it turns out that most infections kind of follow the same principles regardless of what the causative agent is. So first of all, just a simple definition. An infection is present when a microbe or parasite is able to reproduce or live in the body's tissues. And in the body's tissues is never one of those places where there's resident flora. So like in the large intestine, for example, we have the large intestine is like a tube, right? And the bacteria live in here, but this is where the body's tissues are. Technically speaking, the inside of the GI tract is outside the body because it's on the opposite side of the epithelium. So that's an infection. So infections can occur in a wide variety of patterns. You can have sporadic infection, which just means that occasionally people get this infection or this germ, but it doesn't really follow an easy-to-see pattern. An endemic infection is one that's very commonly seen in a particular group. Malaria, for example, is endemic in certain parts of Africa and Southeast Asia. In other words, huge numbers of people have the malaria infection, and that's because that protozoa is endemic, is the word we use there. An epidemic is when lots of people are infected with the same organism in a short amount of time. So in the last 10 years, we've heard about a number of concerns about epidemic. H1N1, the swine flu came around there too. And then a pandemic is what the public health agencies are always worried about these days. And that is where a single organism manages to infect a big part of the world. And the concern there is with, because of air travel and our, world that's getting smaller all the time, that it's easier and easier for a bug from very, very far away to arrive right in your neighborhood. So a pandemic is kind of a worldwide spike in an infection of a certain kind. Yeah?
How do they decide when an epidemic becomes a pandemic?
I would imagine it's when more than one region is involved, they'll call it a pandemic.
Okay.
Yeah. All right. Let's see. So in order for infection to occur, it doesn't just happen. Microbes don't just appear out of thin air or appear in tissues. They have to come from somewhere. So there's always a chain of events that's involved in infection. And we talk about a number of key spots there. One is a reservoir. So because these microbes are alive, they have to have a place to live in between infecting people, so to speak. So a reservoir is just a person, an animal, or an environment where that microbe is living and thriving. In other words, it's there all the time. A reservoir might be a person. It might be an infected animal. And in terms of environment, there are some bacteria that live preferentially, like in the soil, for example. The tetanus bug likes to live there, so it's always there. It's always a reservoir for infection. A reservoir can be a carrier, and a carrier is a person who has an infection but has no symptoms of it. In other words, they are carrying living infective material, whether it's bacteria or viruses or whatever, but they don't have any symptoms. And they're particularly problematic because human beings move around. So carriers can take a germ into many different environments because of their everyday activities. You know, typically when we're really sick, at least, we stay home and we isolate ourselves from other human beings. But these carriers can be out there spreading things around. All right. There are multiple modes of transmission. This is just how did the bacteria or how did the microbe get from point A to point B. So direct is kind of just what it says. This is direct contact with the organism. So it can be from touching it, an infectious lesion, sexual intercourse, direct blood or bodily fluid contact. This is usually the mode of transmission that's most common. And that's because most of these pathogenic organisms, they can't really survive outside of a human being or another animal. You know, they're not durable enough for that. So like the HIV virus is pretty easy to kill on the outside of people. It's just hard to kill on the inside of people. Indirect transmission is where the germ passes from living thing to non-living thing, and then from non-living thing to living thing. So the classic example of this is like the door handle at the bathroom. You know, infection is passed to the door handle, and then when somebody touches the door handle, they can then bring in that infection. That's an indirect effect or an indirect transmission. The word fomite is used to describe any object that can transmit infection. So there again, the door handle of the bathroom is a fomite. Certain surgical instruments that aren't cleaned right could be a fomite. So hands are probably the biggest culprit here because hands create fomites. In other words, hands touch things and the germ gets on the things, and then hands touch those things again and then bring them into the patient. So that's indirect. Droplet and aerosol are both through the air. Droplet is much more common than aerosol. And this is, the classic one here is a sneeze. Somebody sneezes into a room and there are droplets of fluid that explode into the air. Those droplets can be inhaled, and that can be a source of transmission. Aerosol is rarer but much worse. And the difference between a droplet and an aerosol, droplets will fall to the ground after a short amount of time. Aerosol can stay in the air. So if the droplet is tiny enough, the aerosol will stay in the air and even circulate through a building. So there aren't very many bugs that can travel by the aerosol route, but like tuberculosis is one of them. That's why a patient with concerns about TB, we put them in a negative isolation room. In other words, air only goes into that room, it doesn't come out, because that way that aerosol-borne bug can't travel. Meningitis, certain kinds of meningitis, they also think can be transmitted by aerosol. And then vector-borne. This is where some other animal has served as an intermediary between infected human A and new infected human B. So insects can do this, like in the case of malaria, like we talked about. Animals, rabies, a dog gets rabies from another dog and then is a vector to transmit that virus to someone else. All right, so just a picture showing those different modes of infection. What I didn't talk about was ingestion. That just means bringing it in through the GI tract. So like that amoebic dysentery, that's an example of ingestion as a form of transmission of infection. So infected poultry, salmonella, we hear about that all the time, poultry and eggs. Unclean dishes and things like that can spread salmonella as well as other like Shigella. All right, so transmissions. Nosocomial infections are a circumscribed set, and these are infections that result from healthcare itself. So unfortunately, these have always been a problem, and because we pay so much closer attention to what bugs people get now than that we did 30 years ago, we're finding that hospitals and nursing homes and even clinics can be a real source of infection. And it kind of makes sense because, who comes to the hospital? Who comes to the doctor? Well, sick people do. So you're clustering all these different pathogens in the same room, for example. So patients going into or coming out of that room are going to have a higher incidence of disease. And the diseases tend to be worse. The infections tend to be worse. Because any bug that has hung out in the hospital for very long is going to have experienced lots of different antiseptics, lots of different antibiotics, lots of different methods for sterilization. So they get tougher and tougher over time. It's one of the reasons why, like in many pediatrics offices now, there's a sick waiting room and a well waiting room. Because what they're trying to do is reduce this nosocomial infection. The last thing you want your kid to get is the cold from the kid that they're playing with if they're a well child, or even if they're a sick child. But other examples in the hospital, C. diff, Clostridium difficile, is a diarrhea that is transmitted by this organism that's particularly difficult to treat and can be very severe. And then MRSA, methicillin-resistant Staph aureus, is, we think anyway, a version of the Staph aureus bacteria that kind of grew up in the hospital. So it's resistant to many of the antibiotics that we use to treat staph. Another one you could add today, which isn't in your book, is VRE, vancomycin-resistant enterococcus. Just like MRSA, it kind of grew up in the hospital, but it's made its way out into the community even. So we have to really be careful with our universal precautions and quarantine procedures to keep nosocomial infections from happening. Yeah?
With the ones that, like TB, where they need the isolation room, how long after that person checks out does that room have to be empty so the next patient doesn't pick up that as a nosocomial infection?
They have the infectious disease people will have a full TB scrub down. So once that's done, it should be clean for somebody else.
Okay.
Because the air in that room is being sucked out and filtered all the time. So they do come in and they clean it like it's never been cleaned before, kind of thing. Yeah, to prevent just what you're talking about. But I don't know if they give extra days. I doubt it. They probably just do the big cleaning. So why don't we get sick all the time then? If there's all these bacteria and microbes out in the environment. And mostly it's because, we evolved on this planet, so we can handle what this planet can throw at us, at least for most of the time. So typically speaking, the people who are most likely to get infections are not your young, healthy, normal individuals. They're people that have some breakdown in that normal host defense or host resistance, our everyday resistance to the bacteria and microbes that are trying to invade us. So a kind of lengthy list here, but age, young people and old people don't battle off infection as well as young, healthy people do. So we see more infection and worse infection in the very young and then the very old. Genetic susceptibility. We've all encountered this. We have a group of friends and 4 out of the 6 of them have gotten the same cold and 2 didn't. So how does that happen? Different people are differently susceptible to different germs. Some people are particularly susceptible and other people are very resistant. So that varies across the population, which is good for the human species because it means that probably there's no one germ that would kill us all because there's always enough variability that some of us would survive, like you saw in the Black Plague in the Middle Ages. Immunodeficiency, we talked about that last time. Anybody whose immune system is not working at full blast is going to have an increased incidence of infection. Malnutrition, same thing. Any chronic disease lowers host resistance. So even if you just have congestive heart failure, mild form, you're still more susceptible to infection than somebody who doesn't have that. The reason for that is stress on the body tends to reduce immune function because it releases chemicals that sort of suppress inflammation and immunity. Physical and emotional stress, see this point, it's really the same thing. And then anything that breaks down the natural barriers. So like say you have eczema, which breaks down the skin barrier, you're going to be more susceptible to skin infections because there's one less barrier to skin infection. And then an impaired inflammatory response. So this is people who are even taking chronic Advil or naproxen, Aleve. can have a lowered host resistance because they don't respond as quickly to insult or bacteria or viruses that are trying to take hold. When you have more than one of these things, the problem kind of is synergistic. It's not like it's twice as bad if you have two. It's more like 3 times as bad. So the more of these you have, the more susceptible you are to infection. So a few other word definitions. Pathogenicity is the ability of the organism to cause disease. So some bacteria are pathogenic. They can cause disease in humans. Some are not. No matter what they do, they can't cause disease in humans. And then virulence is kind of a measure of how pathogenic an organism is. So the more virulent it is, the more deadly and the greater the infection rate. In other words, the easier it is for it to cause an infection and the easier it is to have that infection get out of control. All right. So where do they get this virulence? Where does that come from? It comes from the characteristic of the organisms themselves. So some bacteria, like the ones that live in our large intestine, they're pretty good neighbors. They don't try to get into our tissues. They don't try to upset the environment. They're just happy to live out their lives and divide. But other bacteria have some of these qualities which make them more pathogenic or more virulent. One is invasiveness. Like we talked a little bit about last time, some bacteria produce enzymes that actually break down our tissues, and those bacteria have an easier time getting into our body because they can physically break down the barriers. So how easily it penetrates or destroys tissues. Toxicity, we talked about last time. Some bacteria have toxins that either destroy tissues or cause other symptoms that promote their growth. Like the endotoxins that promote capillary leak or increased capillary permeability. That gives the bacteria more room to live in, more nutrients coming in, so it sort of serves their interest. Adherence. In order to infect, the bacteria has to be able to hold on to the tissue that it's infecting. And some bacteria have evolved binding mechanisms where they can really cling to tissues and then divide their way in. And then finally, it has to avoid the immune system. In the normal healthy individual in particular, the immune system is always out there looking for trouble. It's looking for any kind of problems that the body's having, any kind of infection. But some bacteria, because life on Earth is very competitive, have developed ways to escape the immune system. For example, the Pseudomonas bacteria, Pseudomonas aeruginosa, has developed a slime coat. So it coats itself with this slippery slime, and it makes it so the immune system can't see it. So these bacteria can live in huge colonies that are all covered by this slimy coat, and the immune system doesn't even know it's there, so it can't attack it. That's just one example. Others have capsules that have very little response to the immune system that they can hide in. Others can mutate very quickly. Our immune system works by looking at little tiny pieces of a thing to identify the whole thing. So if the germ can keep changing the little pieces of itself, the immune system can never get a good look at it, so to speak. It can never label it with antibodies, so then it can be gotten rid of. So there's lots of ways of assessing the degree of virulence, but one of those is the case fatality rate. In other words, of the people who get this infection, how many die? So things like the Ebola virus have a very high case fatality rate. Almost everybody who gets that virus dies of a not a very pleasant death either. But then things like influenza have a pretty low case fatality rate. Every year in this country, hundreds of thousands of people contract the flu, but not very many people die of it. So that has a low virulence or a low case fatality rate. All right. So in order to actually get an infection, a couple of different steps have to take place. First, you have to get infection. In other words, the pathogen has to gain entry to the body and find some place where it can start reproducing. Because remember, bacteria don't live very interesting lives. They really live to reproduce, is at least how we think of them in medicine most of the time. So in order to do that, they've got to find a spot that isn't fighting them, in other words, away from the immune system, and that has the stuff they need to divide. So a nutrient source, an oxygen source for most bacteria, plenty of water around, some salt. But once they find that spot, they can start to reproduce. So in the incubation period, this is the time between the initial infection, bacteria enters the body, to actual clinical signs or symptoms. So in viral infections, for example, this is usually 2 to 7 days. It can be longer. Like in chickenpox, it can be 14 to 21 days. And that's because it takes time for the bacteria or the virus to reproduce enough to do enough damage to cause enough inflammation to actually be noticed by the patient. So the incubation period can range. In the prodromal period, there aren't any obvious or specific symptoms, but the patient feels fatigue, low-grade fever. They don't feel well. So in that prodromal period, the prodrome is that not feeling well time before there's specific symptoms that come up. Following the incubation period and the prodrome is the acute period, at least for most infections. And this is when you see clinical manifestations, obvious illness, obvious inflammation at the site of infection. This is the typical, when they come to medical attention is they're in the acute period. And just as a reminder, onset is when, how did the infection begin from the patient's point of view? In other words, when did they start to get sick and how? And it can be insidious. In other words, it kind of snuck up on the patient. They're not really sure when they started to feel bad. Acute, I woke up this morning and my stomach was killing me, or really anywhere in between those two things. All right. And then every infection has a story that we call the course of the infection, and it's going to depend on lots of things. It's going to depend on the organism. It's going to depend on the host. But typically, the course of infection ends when the host overcomes whatever host resistances the organism has. So here, let's look at a picture because it's easier. So here at time 1, this is where the pathogen enters the host. And over here, this is the number of organisms in the patient. So in other words, how many bacteria are there? And then, of course, this is time. So first there's infection, and it takes a little while for that microbe to find a place that will work for it. But once it does, it's dividing a little all the time, and then once it finds that appropriate site, we see an increase in the slope. So the steepness goes up. There are more new bacteria per hour than there were before that time. So in this number 3 period right here, the pathogen is reproducing rapidly. So lots of new bacteria are growing. At some point, the presence of those pathogens are going to trigger some systemic inflammatory response. So those chemical mediators that we talked about on our second day in here will start triggering things like low-grade fever, malaise, where you just don't want to do anything. Oftentimes muscle aches and pains go with this prodromal period. And then by the time the organism reaches this level where there are lots and lots of them, that's when you start to see the acute signs. So like in flu, for example, this is where you're going to start seeing the cough, and you're going to start seeing the runny nose and oftentimes the sore throat. So you actually start to see signs of an illness, not just the vague, I don't feel well of the prodromal period. So then from there, now we have an acute infection. So the body has to do something about it because there are now enough pathogens that it can either get really, really bad or it can start to get better. So in the normal case, by about this point, the immune system is starting to fight back. So we start to see a decline in viral numbers as the host defenses start taking an effect. And once they do, the nutrient supply decreases, so there's no nutrients to reproduce with. Oftentimes, patients might be on an antibiotic by this point, which is going to directly help to reduce this curve. So lots of organisms are dying. And then when we get to this point, now the immune system is really in charge. It's not just fighting, it's winning, and winning big. So typically, this is the spot where antibodies have started to be formed. And once that occurs, we see a pretty rapid drop-off of the number of organisms that are in the infection. So when you get down to here, of course, you're at cure. This is what happens most of the time. So the common curve is up and then steeply down and total recovery. But things don't always go as planned. If the body's immune system can't get a hold of the infection, it just keeps continuing to go up. In other words, the number of organisms keeps getting higher and higher. And if once it overwhelms the immune system, it can result in what we call septicemia, which is death by infection. When you get enough pathogens in enough places, the immune response alone threatens life. You know, when you get all that capillary leakage, systemic inflammation, your heart rate drops, your blood pressure drops. That causes mental depression, which lowers your respiratory rate, and you're circling the drain, so to speak. So we want to catch infections before this point, before they get out of hand. Another less common path is, instead of completely eradicating or destroying utterly the infection, it may kind of reach a sort of balance. HIV, for example, and hepatitis B will do this, where instead of eliminating the pathogen, it kind of sits in a sort of steady state with the immune system. You know, the immune system can't get rid of it, but it's not getting worse either. So a chronic infection can go on even the whole rest of a patient's life. So there are mild signs and symptoms, but really the destruction takes place slowly over time. Like in hepatitis, eventually that virus, even though it's not causing these kinds of symptoms like it was up here, will eventually destroy the liver. So the different courses of infection. So this is the common one. This is the immediately life-threatening one, up to septicemia. And this is the chronic infection, which often has a totally different path than the acute infection does. All right. So the incubation period refers to the time between what and what? And good, you all got the right answer there. So that's the time between entry into the body and the first signs of infectious disease, is that incubation period. It probably gets its name from how we deal with bacteria in the lab, which is, we put a sample in and we have to incubate them until there's enough bacteria to actually see or work with. All right. Oh, we didn't talk about that, so skip this question. An important distinction to make is between septicemia, which many people just call sepsis, and bacteremia. So septicemia is that out-of-control infection that we saw on our graph page. In other words, the immune system is not able to contain this infection. Bacteria are reproducing at will and in huge amounts, and are overcoming the body's defenses against bacterial infection. And septicemia often results in sepsis and shock. Sepsis just means life-threatening infection. Shock has to do with cardiovascular system, so low blood pressure, high heart rate, poor perfusion, blood's not able to get around. Not to be confused with bacteremia. Bacteremia just means there's bacteria in your blood. It doesn't mean anything more than that. So the septic patient may be bacteremic, but not all bacteremic patients are septic, is the rule there. So bacteremia just means there's bacteria in your blood. Normally, blood is sterile, period. Not any bacteria, not anything that will grow under, in an incubator at all. So any presence of bacteria in the blood is a bacteremia. All right. And these we kind of already have talked about. Local signs and symptoms of infection are the same as those of inflammation, which is probably why people confuse those two terms sometimes. And that's because infection is one of the causes for inflammation that we talked about a couple of chapters ago. And that's that redness, swelling, warmth, and pain, the activation of the immune system, which leads to that purulent exudate, and then bringing in the immune system cells to start dealing with that infection. Okay. So how do we find out what infection is present, and how do we decide what to do about it? So in terms of diagnosis, the gold standard is to actually find that organism in the patient, grow it in the lab, so that then we can do all of our tests on it and figure out what species is this organism. And then we can also figure out what antibiotics will kill it. So we call that process a culture. So we take a sample of the infected area or the infected fluid. So it might be blood, it might be cerebrospinal fluid. It might, if it's a skin infection, we might pull out some of that pus and send it for culture. We plate it out, which many of you, probably all of you, have taken microbiology, which you've done in the lab. We see what grows, and then we start doing our tests to figure out what bacteria is present. Now, even though it's the gold standard, it's usually not enough. And that's because you can't make bacteria grow in an hour. They take time. So culture results take 24 to 48 hours. If you're looking at a very sick patient, you don't want to wait 24 to 48 hours to start treatment. So oftentimes we do other tests that come back more quickly in the meantime to help us start treatment at least, which we can then change later. Once the bacteria has started to grow, you can do this neat test. So this fuzzy stuff in here is bacterial growth. And what they'll do in the hospital lab or in your local lab is these little discs have antibiotic saturated into them, so they've been soaked with antibiotic. And we put those on there, and wherever we see no bacteria growth, like here and here, not really that one, but this one, we know that this bacteria is sensitive to this antibiotic. So we call this the sensitivities. So on the lab report, you'll get that what the bacteria species is, and then whether it's sensitive, resistant, or intermediate. So like this one right here, you can see a circle, but there's still bacteria growing. That would be an intermediate. But these two, this would be the best choice probably for this bacteria. All right, but because that culture takes time to come back, we want some quick answers in determining, how sick is this patient and what's going on with them. So one of the tests we get is the white blood cell count. And this tells us, at least the modern white blood cell count, tells us not only how many white blood cells there are per unit volume, but also what type they are. So, we learned that like the neutrophils are specialized against bacteria. The lymphocytes really work in viruses. So when we get our white blood cell count back, we might get something like this. So, we have 22,000 white blood cells. That's elevated. I'm not expecting you to know normals. But then the differential might be something like 60% neutrophils, 10% eos, 10% basophils, 10% monos, 10% lymphocytes. So what that would tell us is that most of these white blood cells are neutrophils. And if this percentage is too high, that suggests that a bacterial infection is present because it's neutrophils that respond to bacteria. So we would call that, for example, a left shift. Now, why left? Because usually on the labs, it's written this way. So the neutrophils are on the left and the lymphocytes are on the right. So a left shift means that there's many more neutrophils. That suggests a bacterial infection. And a right shift means that there's many more lymphocytes, and that suggests a viral infection. Other blood tests we do really just look for generalized markers for inflammation, like the C-reactive protein and the erythrocyte sedimentation, right? We talked about those before. If we want to be sure that a patient has an infection, we may check antibody levels. But of course, we can't do that until 2 to 4 weeks after the infection. So the only way to confirm that you had a particular infection is to check your antibodies in a month to be sure. And then we use lots of other tests to try to find the site of infection or diagnose what's going on. You know, we might do a chest x-ray to look, because a pneumonia will darken or actually lighten, make more white an area of the lungs. An abscess in a bone, for example, is something you pick up on x-ray. And then once we've made our diagnosis, you know, then we're going to decide on a treatment. And we have really great medicines to treat bacterial infection, and we're getting to have more and more that treat viral infections too. But one of the things that we've learned in the last 50 years is that antibiotics are not just an upside or not just a panacea. In other words, they can make as many problems as they solve if they're not used carefully and conscientiously. So more and more, particularly in things like pediatrics, we're not treating infections at all. And the reason for that is, in the normal, healthy patient, their own immune system can usually clear that infection on its own. Yes, it might take a little longer, but the upside is then they'll have lasting immunity to that bacteria or to that virus. They'll never have to fight it off again because their immune system will have learned about it. So that is being done more often. Now, it's not like we just send patients out the door and say, you'll be fine. Usually we have them come back in a week to make sure that it's getting better and not worse and things like that. Widespread use of antibiotics in a, what I call, not very scientific way has resulted in a huge increase in resistance to antibiotics in the bacteria that live, you know, in the country with us. So big steps have been made to try to stop that from happening. You know, the fear is that with all these antibiotics that are in all these patients in the country, that eventually some bacteria is going to emerge that's just going to be resistant to anything we can throw at it. So to try to prevent that kind of thing from happening, some rules have been created about when should antimicrobials be used. So just quickly, the rules. Antibiotics have to be taken regularly to work. You can't take them one day, wait a couple days, take another dose because you feel bad again. That is a disaster. It doesn't work like that. Because in order for the bacteria to die, the antibiotic level in the bloodstream has to be above its threshold. So if this is time and this is blood level, you know, every bacteria has a kind of threshold like that. If the antibiotic level is below that, it doesn't affect it. If it's above that, it kills it or at least stops it from growing. So most antibiotic dosing regimens are set so that we have a curve like this. In other words, the antibiotic level in the blood is always higher than the threshold for that bacteria. When you start spreading doses out too far or skipping doses, what you have happen is this. The antibiotic level drops below, and what we've learned is that this range right here, this is when resistance develops, is when there's antibiotic around, but it's not at a fatal level. So it's important that patients take their antibiotics on time, and that the healthcare decision makers make good decisions about dosing regimens. You know, it's easy to fall for, you know, the mom that says, I can't give this medicine 4 times a day. It's too inconvenient. But if you back off to 3 times a day or twice a day, you start getting into this pattern, and now you're developing resistance again. Now, thankfully, the pharmaceutical companies are always a big help with this, because there's lots of ways of making a single dose last longer, and they're getting more and more creative about that. So that there's once-a-day dosing instead of 4 times a day dosing like there used to be for some medicines. All right. Everybody knows this one. Take the antibiotics, all of them. If you're prescribed 10 days, take 10 days. Don't stop when you feel better. That is something we always have to educate our patients about, because even though they've all been told that, they do it anyway. So it doesn't hurt to remind them every time they're going to be on antibiotics, you have to take all of it. We don't want to have Godzilla bugs out to get us. All right. Some antibiotics are affected by what's in the stomach with them. Like erythromycin, for example, shouldn't be given with dairy products. You know, there are specific little rules that we're not going to go into, but the patient has to be aware of those things and has to be, again, told about how serious those are, because, again, if one of your doses you took on an empty stomach, one you took with your morning glass of milk, you can make this happen again, and you can generate resistance. We try to use as specific antibiotic as possible. In other words, if we can get by with a narrow spectrum antibiotic that just kills a few bugs, that is a better choice than a broad spectrum one, even if that broad spectrum one will still kill your bug. So what's more and more commonplace today is, when we start treatment, we don't know what the bacteria is because we don't have the culture results. More and more frequently, what docs will do, start the patient on something broad spectrum. When they have the sensitivities and species back, change the antibiotic to something specific, more specific for that organism. All right. Allergies to antimicrobials are common. The reason for this is many antibiotics start with molecules made by living things. The classic example is penicillin that actually starts from a mold that used to grow on oranges, or probably still does. So because of that, they're allergenic. A lot of people are allergic to sulfa drugs. A lot of people are allergic to penicillins, the tetracyclines. They're not always the same people that are allergic to all those things. So you have to get a complete drug and reaction history before you start a patient on antibiotics. And then this one should be all in bold and italics because people still get this one wrong, even people in the healthcare field. Antibiotics have no effect at all on viral infections. None. It doesn't make them go faster. It doesn't do anything. All it does is generate resistance. So if there's no proof that it's a bacterial infection, they should not be on antibiotics. And sometimes the whole healthcare team has to be on the same side about this because what a lot of patients want is they want something that's going to make their kid feel better. They want something that's going to make this cold go away. And it's real easy to pick up the prescription pad and fake them, say, okay, this is going to help you, and it's not. So we all have to be on the same team about that. So no antibacterial drugs for viral cases. All right. So we're not going to get into the details about different antibiotics and how they work. That's more of a pharmacology class, which I know many of you have taken or will take. But just in general, an antibiotic is actually, that term means a drug derived from a living organism. Now, is that how we use it in our modern American English? No, it's not. We use antibiotic to talk about any antibacterial. But technically speaking, an antibiotic comes from some living organism. Antimicrobials is a larger class because that includes antibacterials, antivirals, antifungals, and even antiprotozoals, like we talked about earlier. Each of these three doesn't affect the others. So like an antibacterial won't do anything to a fungus. An antiviral won't do anything with a bacterial infection. There are three discrete classes of medications. And then antibiotics come in two varieties. There's the bactericidal drugs. They actually kill bacteria. So like bleach, for example, is bactericidal. It actually kills the bleach. But many of the commonly used antibiotics are actually bacteriostatic. They don't kill the bacteria, they just prevent it from reproducing. So like penicillin, for example, is an example of a bacteriostatic drug that doesn't kill the bug, it just keeps it from reproducing. And then broad spectrum versus narrow spectrum. The most common definition is a broad spectrum antibiotic treats both big classes of bacteria, gram-positives and gram-negatives. Narrow spectrum just treats one or the other. Now, we use these terms a little more in more ways today, and a narrow spectrum antibiotic attacks just a small number of types of bacteria, and a broad spectrum many, many numbers. So it's not as simple as just gram-positive and gram-negative out there in the real world, but for our class, broad spectrum is both gram-positive and gram-negative. Narrow spectrum is either one or the other. All right. And then some of the antibacterial classes, because they've been around so long, they've been modified, changed, new ones have been invented, old ones have been gotten rid of. So sometimes we talk about them in generations, particularly the class called the cephalosporins. There's a first generation, a second, and a third. And the first is the narrowest, and the third is the widest. It attacks the most things. So the older generations are preferred because of their specificity. All right. So even though there's all these different kinds of antibiotics, really they attack the bacteria in just these 4 ways. So one is to interfere with cell wall synthesis. Bacteria have a cell wall. If they can't produce a cell wall, they can't reproduce because they can't produce a new cell wall. And so that synthesis is bactericidal. So penicillins are bactericidal. Sorry about that. I was thinking of the erythromycins are bacteriostatic. So that's one way, attack the cell wall. Another way is to attack the cell membrane's permeability. You know, just like our mammal cells, if the cell has to control what gets in and goes out. If you disrupt that control, you kill that bacteria. So like polymyxin, which you find in Neosporin, it attacks the bacterial cell membrane. Interference with protein synthesis will halt reproduction, but it doesn't actually kill them. So like tetracycline, other of the cyclines and the erythromycins do this same thing. And then synthesis of essential metabolites like the sulfa drugs. Okay. And like I said, GI upset and diarrhea, very common side effects because of the upset in normal flora that comes with it. So today, we don't just have antibacterials, we also have some antivirals that have come into use. And these, again, don't directly kill the virus. Viruses are like really tough to kill because they have a tendency to hide on the inside of cells. So the only way to get to them, to kill them, is to go through the cell first, and that would damage the cell. So we have medicines that increase host resistance, in other words, make cells resistant to viral infection. Those are the interferons, which are actually chemicals we make ourselves in response to a viral infection. And it makes it harder for viruses to get into cells, and it makes it harder for them to trick the cell into making them. And then those that reduce the ability of the virus to reproduce. So similar to bacteria, if you can stop their reproduction, you can give the immune system a chance to get rid of that infection. So there are lots of different medicines that do that second thing. And then the antifungals can either interfere with mitosis. Griseofulvin is one that's used for tinea capitis or ringworm very often. Amphotericin B attacks the fungal membrane. For the very, very sick patient with a fungal infection, you will hear amphotericin B being used. It's often called amphoterrible because its side effects are so bad on patients. They have to be in the ICU, and there's all these things that go with it. Fungus is hard to kill. There aren't very many good medications that don't harm the patient but actually get rid of the fungal infection. All right. We're going to skip some of these because I want to get started on the next thing. All right, so that was infection. You notice that I did not talk about the flu, even though that's in the chapter. The book uses influenza as just an example to go through the very things we just talked about. You know, transmission, the course of the illness. So I may still ask you about flu, even though we haven't gone over it in class. But I thought that that was a pretty easy part of this that we didn't need to go over, and plus many of you would already have heard about flu in some of your other classes. So we're just going to introduce neoplasms. And like I said, since I'm trying to catch up, and I think we'll get there after the next time, I've shortened some of this too. All right, so we're going to start right in on what is a tumor. A neoplasm, this neo is new, plasm is growth, so this is a new growth. And basically a tumor of any kind, whether it's benign or malignant, is a cell or a group of cells that is dividing outside of the body's control. You know, we only want to have as many cells as we need, because for every additional cell that we have, it needs oxygen, it needs nutrients, its waste products have to be dealt with, the CO2 has to be blown off. So the body keeps tissues in careful control in terms of reproduction so that we only have as many cells as we need. But in a neoplasm, the cells have escaped that control somehow. They're reproducing even though the body doesn't need them. So one of the problems that goes with that is these cells use up nutrients. Tumors are hungry is the way people, or one of the things that I learned. They, because they're out of control, they're sort of speeding up all the time. So they use many more nutrients than a normal cell would use. And because they're not functioning normally, they give nothing back. So it's sort of wasted energy for the organism. Typically, the cells are atypical somehow. In other words, they don't look like normal cells. They don't look like a bunch of normal cells dividing. They look like abnormal cells dividing instead. So they're immature or they're undifferentiated. In other words, they don't show the same characteristics of normal cells of that tissue. Tumors get their name, we use the root, which describes either the tissue type or the location, and then we add oma to the end to designate a tumor. So like a lymphoma is a tumor of the lymphoid system, so it's a lymphoma. Two special words are used to describe the most common kinds of malignant tumors. If it's a tumor from connective tissue, you'll remember, hopefully, from anatomy that all of the tissues, or all the cells of the body are of one of four types of tissues: epithelial, connective, muscle, and nerve. So that's all this, everything in the body is one of these four things. Now, muscle cells and nerve cells don't divide. So it's very, very rare to have tumors of those things, except in the uterus where there is a muscle tumor called a myoma. So everything else is either epithelial or connective. So because most tumors come from those two tissues, sarcoma is a connective tissue malignancy. That's actually a cancer. And a carcinoma comes from epithelial tissue. So you'll see these used in a variety of different ways like we see here. So like fatty tissue is lipid, so we call a fatty tissue tumor a lipoma. Glandular tissue is adeno, so an adenocarcinoma would be a malignant tumor of a gland. And then fibro is fibrous tissue, so a fibrosarcoma would be a malignant tissue of or a malignant tumor of fibrous tissue, and fibrous tissue is usually connective tissue, so that's what makes it a sarcoma. There are a number of cancers that don't follow these rules. They either have a special name based on who discovered them or who first learned how to treat them, like Hodgkin's disease or Wilms tumor. Leukemia doesn't fit the question here or fit the naming scheme, but this is white blood cells in the blood, so it's leukemia. So some of them you just have to sort of play it by ear. All right. So what's the difference between benign and malignant tumors? Benign tumors are not normal. The cells of them are not normal, but they're not as abnormal as malignant tumor cells are. So typically, they're similar to normal cells of that type, just maybe with some differences. But they are out of reproductive control. In other words, a benign tumor is still going to grow. It's just not going to do as much damage for some of the reasons we'll talk about later. So benign tumors expand, but they don't invade or spread. So like if this is your tumor, it's going to grow out like this, but it's not going to like break off and spread to some other tissue like a malignant tumor will do. Not all benign tumors are no big deal. In any area where space is important, like in the skull, a benign tumor can be just as bad, just as deadly as a malignant tumor because it's going to push other things out of the way. Another place that you find this is sometimes in the abdominal cavity when a benign tumor gets very large, it actually pushes or squeezes closed some of the other organs in there that need to be open to work. And then malignant tumors are very abnormal. They don't look at all like the cells they originated from. They not only expand like this, but they invade and they infiltrate surrounding tissues. I think I have a picture. Yeah. So instead of just expanding like a benign tissue, and you see these cells, they don't look terribly abnormal. These guys, all the cells look different. They're not expanding in a nice capsule. They're sort of invading their way through things. Malignant tumors invade blood vessels. And all of you know about metastasis, where a little piece of a tumor will break off, travel through the bloodstream, and then start a tumor somewhere else. So malignant and benign. So the cells in the benign are similar to normal, in the malignant varied in size and shape. Benign tumors tend to grow very slowly. The mitosis is fairly normal. In other words, the rate is fairly normal. But in cancer cells, mitosis is happening very quickly, and the cells don't even really get a chance to mature before they're already dividing again, which is part of what makes them so abnormal. The capsule is kind of a big deal too. Benign tumors are very easy to remove because they're in their own little container called a capsule. So, you cut the skin here, you dig it out, and that's it. The wound heals. In a malignant tumor, there is no capsule. So in order to get this whole tumor, you have to sort of cut a bunch of normal healthy tissue out too to make sure that you've gotten it all. And they're invasive. So they tend to send out little fingers between cells. So sometimes even a tumor that looks small might actually have tendrils like this in the body because of how malignant tumors invade surrounding tissues. All right. And I think that's where we will end for the day. And we'll start talking